right. Thank you so much for having me. And I turned to my table and I said, why do I have to be the one to follow that panel? But I think it is quite a privilege to be that person, and I'm very happy to be here. And thank you for all patients and caregivers. You remind us every day of why we're doing what we do. So without further ado, I'm going to share some of the work that we've been doing on using digital health technologies to quantify limb function and activity in ALS. I personally do not have any conflicts of interest to report, but some of the work presented today was funded by Biogen and MT Pharma. So, quick objectives. I'll go through the background, how we've been using digital health technologies, some of the lessons learned, and then some considerations that we have related to using digital health technologies. I wanted to start off just by making sure we're all on the same page when we talk about digital health technologies, and the FDA defines them as systems that use software, sensors, computing platforms, and connectivity for healthcare. Okay. And for the purposes of this presentation, I'm going to focus really on smartphones and wearable sensors, both of which can capture active and passive data. And when I talk about active data, that could be surveys that people are completing for us, or if they're doing a specific task or an exercise with either the smartphone on them or with the wearable on. And passive data is where we just ask that they have the device on them, and then we're collecting information from the GPS, the accelerometer, gyroscope about different movements or activity patterns. So, why did we start using digital health technologies? I think most of us in this room probably know that there is room for improvement in our measurement in ALS, and our traditional measures like the ALS-FRSR revised, vital capacity, handheld dynamometry, well, they have their benefits. They also have limitations, and some of which they're not always sensitive enough to capture changes that patients are telling us are meaningful. They often rely on in-person visits and consistency with evaluators, which is not always possible. And so what do we end up with? Well, we have a lot of negative clinical trials. And is this because the therapies aren't actually working? Or is it because our measurement tools aren't able to capture the meaningful changes during that study duration? And so in order to answer that question, we need to make sure that we have really robust outcome measures. I would also argue that there are impacts on clinical care, and at least in the US, if someone needs a communication device or a power wheelchair, insurance really doesn't cover it until they need it, which is too late because then it takes several months to get that equipment for them. And my hope is that if we have more robust outcome measures that can very accurately predict when someone might need that equipment, then we might have a better chance of convincing insurance companies to approve them earlier. We're not there. I hope that's where we're headed. So the kind of low-hanging fruit when thinking about digital outcome measures really was surveys. You can put surveys on a smartphone and administer them really as frequently as you want and as frequently as participants are willing to complete them. And so in the next few slides, I'll just show examples with the ALS-FRSR where we have done this. And this first one is a 24-week study, weekly collection of the ALS-FRSR on a smartphone app. That's the BWE app. And then staff-administered traditional collection of the scale at every 6 weeks. And on the x-axis here, you have the patient-reported FRS scores. The y is the in-person. And while it's not a perfect correlation, that gray line would be that perfect correlation, it's very close. So this was 0.93. And the shift of that red line to the right of the gray shows that our patients do rate themselves higher than we do. This has been repeated a few times. This was another study. We looked at 3 different time points and saw the exact same thing. This time, the y-axis has the self-reported, which is why you see the blue lines on the other side of that dotted line. But again, very high correlations, and patients are slightly rating themselves higher than what we get with the staff-administered. one more example. This was a 25-week study, again with the weekly administration, and then the staff administered this time was every 12 weeks, and we see the exact same thing. So it is very reliable way of collecting at least the FRS, and it can be done with really any other questionnaire. We did take that last study one step further to see, well, what are we gaining from this increased frequency? And so what you're seeing here are panels of the total FRS score and then each of the subdomains, fine motor, gross motor, bulbar, and respiratory, and the estimated monthly change. And what we see is that, I guess, let me go back a step. In each panel, you see the traditional staff administered, FRS collected every 3 months, the digital, if we were to collect it every 3 months, and then the digital at monthly, every 2 weeks, and weekly. And while the point estimates don't change, it's those confidence intervals that do come down, which increases the accuracy of our estimates and can make for higher powered studies or more efficient trials. I will note here that at least for this study with this group of participants, the 2 week to the 1 week wasn't much different. So we maybe don't need to be asking them to do it as often as we are. So then we wanted to take it beyond surveys, and what else can we get? And this is smartphone data quantifying activity levels. And here, what you see along the x-axis are different participants. Those are individual participants, and on the left we have their home time, and that's their time spent at home, collected by the GPS data, and then distance traveled from their home. This data represents the first month after they completed the self-reported FRS, and it's their median score with those interquartile range. So we can see here that we are able to collect and quantify how much time people are spending at home and how often and how far they're traveling from their homes, which may have implications for social connectedness and possibly loneliness or isolation. We are starting to look at that more to see if this is actually meaningful. Another representation just to show how much we can capture these behavioral changes. This was actually 8 people who were using the BUE app at the time of the COVID lockdowns, and we looked at their GPS data for 1 month prior and then 1 month after the lockdown, and you can see those very expected changes where our patients went from spending quite a bit of time at home to almost all of their time at home, and their distance traveled decreased significantly. That line that you see in the middle is the US state of emergency when it was declared. So the GPS data can capture these behavioral changes. This is just a very stark example. So what about walking? Can we get information from the smartphone about walking cadence or different gait metrics? And in this, it's the same study as 2 slides ago. Again, you have the participants along the x-axis, and now we're looking at cadence. The cadence on the left, and then the walking cadence from their top minute in each day on the right. And again, it is the median from that first month and the interquartile range. And you can see that, yes, we can capture some information about walking from smartphone. But do these change over time? We can capture the data. Can we capture changes over time? And so from that same study, we picked 8 metrics to look at. 3 of these did meet significance when looking at monthly change over time. 1 was trending, and that's the walking cadence from the top minute. The 3 that were changing were the activity index and then the step counts, both from their daily step counts and that top minute. And then the next step that we wanted to look at was, can we capture changes in limb movement? So this study, we had participants who were wearing an actigraph watch on one of their upper extremities, and we were capturing different movements of that extremity. So the C on the y-axis for each of these are their counts of movements. The F are what we called flexions. That was any time the arm was elevating. The E were the extensions, or any time that arm or the watch was coming down. And then the S and the P are your supination, pronations, or the rotation of the forearm collected by that device. And we see that over 6 months, these counts were coming down. Each of the colored lines represent a different person in this study, and then you have the average across. So we can capture changes in the extremity. We also looked at the duration of those movements. So while the number of counts are coming down, they were also taking longer, which is what we all, I think, clinically see happening, but this gives us a way of quantifying it. And then this image to me is quite striking. This is one individual's raw data from that same study, and looking at day 1 up to day 141, each gray dot is a single point of when movement was collected, and then the lines represent when there was more than 90 degrees of motion into the flexion or the elevation of the device. And so you can very clearly see we are able to visualize the decline in function at that limb. And again, this gives us a way to quantify what we see in clinic. That was a very small study, and we have been able to replicate these findings with the use of the ALS TDI data set, where participants are wearing the ectograph watch for a week at a time each month and bilaterally. And this was under review when I submitted these slides, but it was just accepted and will be printed soon. So more to come on that. And then I wanted to spend some time talking about lessons that we've learned, because it's been kind of a painful process along the way, but we really do feel it's important to improve our outcome measures. So effective use of digital health technologies really does require manpower, and more than we expected. You cannot just set patients up, even with an app or a wearable like a watch, and expect everything to run perfectly. Technology doesn't work that way. And so you do need people monitoring the data and having frequent touch points with participants to make sure that you are getting the data that you expect and want to be collecting. Adherence matters. These are observational studies that patients are very willingly giving their time to help us improve our measurement. And the last thing we want to tell them is we couldn't use their data because they didn't wear it enough. So talking with them about what adherence we need to make the data meaningful. And I wanted to just show very quickly here a difference in the GPS versus, which is passive data, versus more active data, and then comparing. This is 3 different studies, but I'm just going to look at the first 2. The first is a 12-week observational study compared to a year-long, and the data completeness is along the y-axis there. And what you see is, for shorter studies, our data completeness, especially in these observational studies, is going to be better. And really the GPS data, or that passive data, we have more data completeness, which probably plays into the participant burden. So with any of these, with all of the outcomes that we're collecting, there is participant burden, and we need to understand that. And I think Dr. Bedlock mentioned that we are collecting a lot of data, and we need to recognize that. That burden can mean different things for different patients. We've had some patients say just putting a device on reminds them that they are declining and that we are tracking every little thing, and that they didn't want to do that anymore, and so they dropped out. It also, sometimes just getting the device on or dealing with any of the technology issues can be quite burdensome. So keep that in mind and have open communication with the participants so we can try to improve things as we move this forward. An interdisciplinary team is key. We have a large team, well, I consider it large, but a team working on this from the beginning of study development, talking with patients and caregivers, our research coordinators who are carrying out these studies, the statisticians who will be looking at the data, and really it takes a team to figure out what data is meaningful and how we might use it moving forward. But it's really important to know what the purpose of your digital health technology is. Is it to identify symptoms, to track progression, to evaluate treatments? And if you don't have a clear understanding of what you're using it for, it's going to make it very difficult when you have all this data in front of you. You'll likely get lost in it. And then I thought I had an image here, but otherwise I did not, so it's kind of a boring slide, but considerations for digital health technologies. Cost is there, especially when you add a wearable, but also the manpower behind it. If you can use smartphones, that may help with cost savings. Think about wear time. How much do we actually need our participants to be doing? Where location? How does and then have a plan for your data transmission and data monitoring. For smartphones, there's a few more considerations. I'll just go down to the device usage. You want to make sure you know how your patient or participant is using their phone. If someone else is carrying their phone, you're collecting someone else's data. So we talk with our patients regularly to understand how and when their phone is with them. And then most importantly, participant engagement. As we are developing these new outcome measures, and if we plan to implement them into clinical trials and clinical practice, we need to understand when and how these might improve things for them and make their contributions and that participant burden worth it. So with that, I'd like to thank all of our participants and caregivers who have participated and continue to participate in all of our studies, our entire team at the Healy Center, especially Dr. Barry, who has led most of this work, and Sabrina Paganoni, who's my research mentor, and then many other collaborators and partners that have helped make this work and some of our other projects possible. No. Yeah, they keep turning it off on you.
It's not the technology, it's first. So energetic. Okay. Oh, yay. I was just going to say, the technology is extraordinary. It was about less than 10 years ago when we did at our center, we did a trial with a Formula One driving company where they stuck a probe onto our chests for a week. And that basically only gave our heartbeat. At the time. And now we are all walking around with these mini computers that give so much information about everything we do. I can't even tell you if I slept well until I've looked at my app. So, has anybody got any questions for Katherine?
Great. Perfect.
You've stunned the audience. Oh, yes, we do have a question at the front here. May we have a mic?
Right in front.
Sorry, you're probably all getting tired of my voice. I'm David Busak, a patient fellow. So you had a few slides that had some large data sets showing generally consistent trends in a lot of the lines that we saw. Consistent downward, or I think consistent upward. But in each of them, there were one or two traces that were going in the other direction. So I was curious about that and what that tells us about those particular patients, or why we had those wayward lines.
That's a great question. So we've asked that question to ourselves a number of times, and actually in that recent paper that's coming out with the larger data set from ALS TDI, we see it again and in a larger group. And we haven't pulled them out to look at them yet, but it's definitely something that we want to look at. My initial thoughts for some of them were these people in the tofersen study. In a lot of these observational studies, we keep track of if they're in a clinical trial, but not which one. So getting more information about their treatments, whether it's a clinical trial, an EAP, or supplements that they're taking, I think would help answer some of those questions, but we haven't dug into them yet.
Good. Any more questions? No, I think that just leaves me to thank you, Katherine, for a very interesting speech. Thank you very much.